This is our Symbiosis International University that we proudly represent at SYMHEALTH 2017. Now, we have an eminent scientist of international acclaim amongst us, Dr. Soumya Swaminathan. I kindly request ma'am to grace the dais. Now, I kindly request Dr. Vidya Yerwadekar, Principal Director, Symbiosis, to felicitate the madam. Dr. Soumya Swaminathan is currently Director General, Indian Council of Medical Research and Secretary, Department of Health Research. She brings with her a vast experience of 23 years in health research and research administration. After completing her MBBS from Armed Forces Medical College, Pune, and MD in Pediatrics from All India Institute of Medical Sciences, New Delhi, she acquired fellowships in subspecializations of pediatrics from various renowned universities abroad. Her exemplary work has won her many accolades and awards like ICMR Shanika Oration Award, Tamil Nadu Science and Technology Award, and ma'am is a fellow of India's top 3 science academies. Dr. Swaminathan looks forward to focusing on key health priorities and generating scientific evidence for achieving public health impact. Now, I kindly request epitome of knowledge and vision, Madam herself. Now, I request Dr. Rajiv Yerwadekar, Dean, Faculty of Health and Biomedical Sciences, Symbiosis International University.
Sorry, this is breaking from the tradition, but I was not supposed to be speaking before Dr. Swaminathan. But Dr. Soumya, if I could take the liberty of mentioning to this audience your exemplary commitment to this, attending this session. Dr. Soumya Swaminathan was in the US, and she took an 18-hour flight, I guess, from the US, came down into India at the T3 terminal, took the 11:30 flight from Delhi to Pune, just to be in time for this inaugural session. And then she's going to go back to attend a meeting at the PMO in the afternoon. And I believe from there on, she's got a commitment in Rajkot, I think so, tomorrow or day after. So, ladies and gentlemen, please put your hands together and a very warm welcome and an exemplary commitment on behalf of people in leadership positions, something which we need to learn. Thank you, ma'am.
Thank you, ma'am, for sparing your time for our SYMHEALTH 2017. Now, I request you to please commence the session.
Dr. Rajiv and Dr. Vidya, other senior management and faculty of this institute, distinguished speakers and participants at this conference, and all my student friends. I see a lot of young people in the audience, which is always very nice for somebody like me. I should apologize that I'm rushing in and out. My plan was to actually spend some more time here listening, because this kind of an interdisciplinary conference looking at different aspects of healthcare would really have been not only interesting, but I'm sure very informative as well. But because of other commitments in Delhi, I'll have to leave soon after this session, so my apologies for that. Perhaps what I want to do today over the next few minutes is to just, maybe do some loud thinking about the kind of priorities that we have in India in the healthcare scenario ahead of us today, and what one needs to do or could do to really contribute to achieve this goal of universal health coverage that we've had for a long time. All countries committed during the Alma-Ata conference in 1976 to universal health coverage. But many countries, including India, we are still struggling to actually deliver on that. And there are many reasons for that. There are many challenges. But I think today we see a renewed commitment to achieve this goal. And we need very concrete action on the ground to be able to do it. So let me start by talking about the burden of disease in our country today. Traditionally we have had a huge burden of infectious diseases, and a lot of our focus in the first few years after independence was in tackling infectious diseases as well as in maternal and child mortality, which were very high. At the time of independence, around there, our life expectancy was only about in the mid-30s, and today we have a life expectancy which is almost 70. It's a little higher for women than for men. So we've made a huge gain in that. But when we look at other countries which are similar to us, either in terms of economic development or are our neighbors in the region, we find we don't do as well as, say, Brazil or China or even Sri Lanka. We have several years less life expectancy. Again, we have a marker called the healthy years of life lived, which means that your quality of life is good and you're productive. So again, when we look at that, we find there's a 10-year gap between life expectancy, the age to which we live, and the age till which we are actually healthy, which means the last few years, or 8 to 10 years of life in India, there's a huge burden of chronic diseases. So what are these chronic diseases, or what we also call non-communicable diseases as opposed to communicable or infectious diseases? These are cardiovascular disease, diabetes, hypertension, stroke, chronic respiratory diseases, and cancer. These are growing, and it's natural that they will increase because as you age, these diseases tend to increase with age, but they're growing disproportionately to the aging population. So there's a group which does something called the Global Burden of Disease, and every year they come out with an updated version. This is a group in Seattle called the International Health Metrics Institute. And we are now working with them to try to document the disease burden state-wise. Because as you know, it's difficult to have one number for anything in India. You can find everything from the most developed country. If you take statistics of Kerala, for example, they are as good in terms of health indicators, infant mortality, maternal mortality, etc., as good as any of the best European countries. Scandinavian countries have the lowest infant mortality in the world, and Kerala is there, single-digit infant mortality rates. And then you take certain districts in Assam or Bihar or Chhattisgarh or UP, and you find that some of our health statistics are worse than sub-Saharan Africa. So we have the entire spectrum within our country, and that's one of our challenges, is the heterogeneity, not only in geography, but in many other factors, including health systems. So we are working on a state-level disease burden estimation, which will tell each state what exactly is the health profile of their community. And this is done by collating every possible data that's available and then doing some modeling to arrive at this. One of our major challenges really is, when you want to know about the health of the population, you need markers, you need indicators, you need data. And one of the important sources of data in Western countries is the vital registration system, where every birth and death is recorded. And not only that, the cause of death is carefully documented, and this is done by a system called the International Classification of Diseases, and this gets updated every time, every few years. We're using the ICD-10 now, so that by looking just at your data that has been routinely collected, the country knows. Now, the problem in India is you'll be surprised that less than 20% of deaths overall have a medically certified cause of death. Majority of deaths that occur in rural areas never have that, and even in urban areas, if you go to big hospitals, teaching hospitals, medical colleges, the death records are very poorly maintained. This means that we don't have a good idea. So again, importance of data is absolutely critical. And I think even in this area, I'm told Symbiosis has adopted a number of villages around this area. I think if, in addition to running the camps and providing the services that we saw in the film, one could actually do a census and document the baseline health status of the population and then follow up over a period of time, you will learn a lot of very important things about the population. So kind of what we call cohorts, community cohorts, need to be built and maintained. There are some very good community cohorts that we have, including one in Vadu, which is not far from here, that was started by KEM many, many years ago. But we need much more of those to actually give us this kind of data. So another project that we are working on is how do we improve the cause of death documentation in hospitals. It has to occur by, not only by training doctors, but also by ensuring that every hospital has a system to do this, maintaining records. And in rural areas, we would have to find a different approach of not only documenting the death, but trying to arrive at a cause of death. And in the absence of such data, one has to resort to other types of data collection methods like surveys, periodic surveys. We have a number of surveys that collect health information. The biggest one is a National Family Health Survey, which occurs every 5 years or so. And then apart from that, you have the NSSO, which also collects data on health. You have the SRS, and then you have otherwise surveys which have been done at different time points and given up. The ICMR used to run the National Nutrition Monitoring Board surveys right from the 70s. So we have longitudinal data on nutritional parameters in urban, rural, and tribal areas over the last 40 years. So it's very, very useful. It's like a gold mine of information which you can look back at the health of the population. But what we really need today is a comprehensive health and nutrition survey that can be performed periodically, that can collect data on different aspects. Like I said earlier, our focus used to be infectious diseases, maternal and child health. Today, 55% of the disease burden in India is because of non-communicable diseases. 35% is still due to infectious diseases and maternal and child health causes and nutrition. And injuries and suicides forms an increasing proportion, about 12% of the disease burden in India is because of that. So the causes of death, when we look at it, tells us important things. Like, for example, suicide is the #1 cause of death in young people, 15 to 29 years of age. This is true in many countries of the world, but it's really a huge number in India. And it tells us that we need to pay attention to our young people, our adolescents, kids who are passing out of school, going into college. And then after that, why are they committing suicide at these high rates? So this brings, again, spotlight on diseases or conditions we've neglected in the past, like mental health. We need a huge program for mental health, not just in adolescence, but at all different stages of life. And mental health is, at one extreme, diseases like the psychosis, depression, and schizophrenia, and so on. But otherwise, when you look across, the recent National Mental Health Survey found that over 10% of Indians suffered from some disorder or mental health disorder or the other. This can range even from things like depression. And then, of course, you have the addictions to alcohol, tobacco, and so on. So the big risk factors today that affect our health are hypertension, and hypertension is something that's asymptomatic. You don't realize that you have high blood pressure till you get some complication or the other. So by that time, it's already too late. And about 15% of Indians have hypertension. And again, as you age, the percentage increases. Diabetes, we keep hearing these figures. 60 million Indians have diabetes today. Again, the ICMR had done a large nationwide study called the INDIAB study, which found that the prevalence of diabetes is related to the so-called developmental status of the state. So if you look at states like Kerala, Tamil Nadu, and Punjab, they had the highest rates of diabetes and pre-diabetes. You look at states like, Chhattisgarh, where people are still living more in the rural areas and still have not urbanized as much, you find that diabetes rates and pre-diabetes are lower. But the fact is that it's increasing everywhere, and urbanization is something that is going to affect all states in the country. So this is what we call lifestyle diseases or lifestyle changes. Increasing urbanization, you become more sedentary, diets change, and then of course there's also behavioral things like tobacco and alcohol which add to this burden. Another very important risk factor today in India is the air pollution, and this includes both environmental as well as indoor air pollution. 60 to 70% of our rural women still use solid fuel for cooking. Of course, now we have this program, the Ujjwala program of the Prime Minister, which is trying to give LPG connections to at least 50 crore families below the poverty line. And this is going to have a huge impact. But early data from this program shows that while the uptake is very, very fast, and because of the discount that's given, people are actually buying the LPG. But if you look at the usage, it's not as much, perhaps because the cost of the cylinder or for other reasons which still need to be explored. So in many rural areas, when I ask women, why do you still use, when they have access to LPG or other methods of fuel, they say the taste is different, the roti has to be cooked on a wood fire or a coal fire and so on. So there are many behavioral things which need to be looked at, not just the provision of services. Similarly, the sanitation program, the Swachh Bharat program, just building toilets is not enough. We know now from looking around that unless you have behavioral change in the community, I used to live in Chennai on the beach, and very often in the mornings what you see is basically people collected over there for open defecation. And we used to ask, even after toilets had been built, and they used to come up with answers like, well, the seawater will kill all the germs, this is not harmful, it's much better to be out in the fresh air, and so on. So again, it's a question of a movement and changing behavior. So a lot of health is really related to behavior, whether it's your diet, whether it's your habits. And therefore, it's not enough to have just the biomedical inventions or discoveries. A lot of it is to do with community involvement. And in many areas, you need socio-behavioral research. So I often say that sometimes public health programs fail. If you look at a program like the Mass Drug Administration that we have for filariasis, you know that filariasis is one of the diseases that we are hoping to eliminate in the next couple of years. And for this, the government has a program wherein over 250 districts in the country which are endemic for filariasis, they go out and give every person in the community a dose of diethyl carbamazine and albendazole once a year, which kills the microfilaria.